So it's my great pleasure to welcome everybody back this morning. Yesterday we had an excellent session and we had a total of 192 participants yesterday, which was very good. And for those who were not there yesterday, I will reintroduce some of the panelists. Uh, Dr. V.C. Chauhan is from Bilal Amin Hospital, is a very well-known senior interventional consultant. Dr. Prashant Jagtap, who is a very good friend. He now has his own hospital, the Viveka Hospital. He's a very senior interventional cardiologist. Kirti is my classmate, a very well-known cardiologist from Bridge Candy Hospital. Arun is, of course, got famous all over India in a very short time after he returned from US, and he is one of the most well-known guys for CTOs and retrograde CTOs. Asim is from Asahi, and he is going to give us an insight into the wires. So I have not forgotten Dr. Abhi Mehta, but I actually wanted to introduce him last because actually I can't introduce him because I don't know, I just remember of an advertisement. Many of you might remember there was an advertisement कि ये PSPO नहीं जानता. So it is that kind of thing. So you can't introduce Amitabh Bachchan by saying how many movies he worked in and how many shows he hosted. You can't introduce Sachin Tendulkar by saying how many tests he has played. He's just Sachin Tendulkar and he's just Amitabh Bachchan. So similarly, he's just Dr. Ashwin Mehta. So he's my teacher. I will just, without taking too much time, I will just mention a couple of things that how passionate he has been, and I am been very lucky and privileged to work with him for quite a few years as a student and then as a lecturer. Is that on a Diwali night at 3 a.m., once he came down to Sion Hospital to perform a primary angioplasty when primary angioplasty was in its primitive kind of stage, and we had to really spend a long time in doing primary angioplasty. And on a day where it was raining very heavily and the whole Bombay was flooded with water and all roads were waterlogged, he came down to Bombay Brasserie and I came from Sion to Bombay Brasserie restaurant in Worli to desperately, urgently sign some documents to get into ethics committee for first ever trial of primary angioplasty, randomized trial of primary angioplasty in India. So that was his passion, that he didn't even postpone it to the next day morning because we had to get the documents in. And I'm really privileged to have such a teacher and such a guide. Of course, not to mention that he paid for the dinner, but
okay.
So I think Kirti, you can start the proceedings for today with your talk and set the ball rolling.
Excellent. So I'm going to share my screen. Can everybody see the screen?
Yeah, we can.
Okay, great. I completely, I share Atul's sentiments regarding Dr. Mehta, and he has been a teacher who has actually inspired us, and probably one of my early exposures to CTO angioplasties practically after my training abroad in India was under his mentorship around wherever he did them and performed all those sessions in those early years. I just have, this is a talk which I prepared around 5 years ago. And basically it talks about the fundamentals of CTO approaches. Some of the slides in this talk probably reflect the thought process of that time, but I thought this talk would be the best way to kind of understand why we need to have specialized equipment and why we need to have specialized wires and microcatheters and what have you for CTO, understanding the pathogenesis and the morphology of lesions that we talk about. I think to start, if you go into the history, you know that we had the USCI steerable intermediate standard wire and the ACS high torque floppy wire. I think Atul and I both have been familiarized with these wires with Dr. Mehta. And we had a very low success rate as published in those years. There was a lack of stiffness. There was no information on the CTO structure. There was no basic concepts. It was a trial and luck. And if it worked, it worked. If it doesn't, then you gave it up. And there was a very large percentage of patients which actually were not treated successfully. And actually, Grunzik in one of his treatments said that the future of coronary angioplasty lies in our ability to win over the chronic total occlusion, the true chronic total occlusion. The two big stumbling blocks we soon realized were the subintimal dissections and the proximal fibrous cap, which was tough to pass. The failed concepts of this period were the magnum wires, which are heavy-duty wires, then high-speed rotational atherectomy burr to kind of, see if we could ablate the proximal cap, low-speed burrs by Kaltenbach, the vibrating wire. I remember talking about it, and I think Jeffrey Hartzler talked about it. And then came the wires which had radio frequency, which was actually a thought process which was steered by Jeffrey Hartzler. All these didn't work really. The penetration of the hard cap and the smooth wire handling in the CTO body was an issue. Visualization of the missing segment was the next thing. So I think the next thing that really happened was the simultaneous angiography. And this happened between the 1995 and 2000 period, simultaneous retrograde angiograms. And that gave us a concept of missing segments. And we realized that the lesions that we actually crossed with those earlier wires were actually probably not true CTOs. They were actually false CTOs. And the minute you do simultaneous retrograde angiography, some CTOs, which appear CTOs antegradally, actually disappear. They don't remain those CTOs anymore. We had a very early prediction by Puma of failures, which you all know, and I'm not going to reiterate those. But what was happening was the world got divided between outside Japan and in Japan, and you can see that the failure rates and the success rates for CTOs and the complication rates were listed over here.
Kirti, sorry to interrupt. There are a couple of messages. Can you be a bit louder?
Oh, sorry. I'm so sorry. Okay. Can you hear me well now?
Yeah, we are able to hear you before also, but I think you can just increase your voice a little bit.
Okay. I'll do my best. So, the world got divided between outside Japan and Japan, and you can see that in Japan the success rates were higher than outside Japan at that time. And the important thing was outside Japan, most of the philosophy was regarding the lubricated polymer wire, which was an automatic CTO negotiation, like the Shinobis, the Choice PTs, and the cross wires of Terumo at that time. And basically in Japan, they were talking about high tensile strength wires with penetration, and they started talking about the Miracle family and the Confianza family from the Asahi. And I think this was a big radical change which actually happened. Also around that same time, I think this was the wires, and the philosophy was the stiffer the wire, more successful. So, people were actually going for the stiffest of wires. And even after having the most stiffest of wires, I think one part of the philosophy was here. And the difficulty was to maneuver them in the CTO body. The loose and the soft and the loose tissue were negotiated. But the problem was with these as the wire got stiffer, deflectivity and maneuverability was lost once it was within the CTO body, and that was a problem. And this was the time also when the wires were being used without any major microcatheters in that sense. The second philosophy was the increased lubricity, which improved the success, and there were different lubricities which were involved with the wire technology, and it kind of divided the wires into various categories. Besides lubricity, there was also this tactile sensation, which was important. But as you know, that as you increase lubricity, you actually lose on the tactile sensation. And that was a problem. We had lots of perforations, we had wire exits, we had propagating antegrade dissection and lack of tactile feel. And here was a group of angioplasties that we all did in that period, where the wire decided the fate of the angioplasty, and the operator had very little control. And then came the next phase, which was in that latter half, closing to 2000, the Confianza and the Miracle family. And and much has been said about this. And these were the taper tip, hydrophilic, more penetrative power. There was a stiffer tip, torque control, tactile. Though both these wires were great to torque within the structure, but the torque was not necessarily 1:1, and there was a lot of whipping effect at that time. And the question was, most of these wires, there was penetration, there was talkability, but we commonly escalated wires to a stiffer wire, and came the philosophy of the escalation of wire came around this time. So redirect with active wire manipulation and re-entry from false lumen to true lumen were the two ways to kind of complete an angioplasty. This is from an earlier time. You can see we started using the fine cross micro catheters at that time. Our earlier wires were the wire Fielder XT. And here we escalated to a Conquest Pro, because beyond a certain point in time, when you were in the CTO body, some of these wires did not kind of work. The Fielder XT did not work. And the Conquest Pro was then limited to those which was disease-free targets, which was perceived as a straight course of the wire. But in all of the wires, we kind of had a choice of wires which we had to go through outside the Conquest Pro when there was disease distal target and a perceived bend in the course of the artery. The Fielder wire would fail at a certain point, because this is when the Fielder XT was introduced at this time. And what was interesting, because it was seen that a lot of the failed cases, even with the stiff wire, was successfully treated using a Fielder XT wire at that time. And it was a great design. But the problem with this wire is that once you enter the CTO body, it quickly loses, and you lose the tip. The tip is lost after a while. And then came the series of this Ultimate Bro wire, which we used in this particular case to kind of manipulate into a tortuous course of the wire path. And this was at that time that things started moving, that we didn't have to be stiffer all the time. You have to kind of you have to have this open mind of changing wires as we progressed into the CTO. So you could start off with a soft wire, you could then quickly go on to something which is a little more stiffer, and then come back to a softer wire as you progress. And so I think the whole idea was manipulating different zones. This was one such case where sometimes when we use these wires, we were just not able to get into the true lumen distally, and often we would get into a branch, but it was impossible to renegotiate into the true lumen, into the distal true lumen. And that's when the concept of the re-entry true false true came in, the permanent loss of true lumen, the permanent loss of side branches leading to limited revascularizations. There were many techniques which were used, and this was the next phase of angioplasty. This slide is very commonly seen, popularized by the Japanese group. And then we started with the second wire. So we left the first wire in place, and we used a second wire, which was of a different stiffness, preferably shaped. The first wire actually changed the organization of the artery, allowing the second wire to kind of have a better chance at getting across the true lumen. The problem was, in spite of all this technique also remained quite blind. There was propagation into the dissection planes, into the side branch. So here we had this this LED where we used multiple wires. Both of them exited. None was finding the true lumen. And I think angiographic guided finding the intra-plaque wire path was an important skill at that time. And came the concept of a parallel wire technique. It was path breaking at that time. However, even though it was path breaking, the true parallel wire technique, as we always understood it, was a blind technique, but it did set up the platform for all future interventions. As you know, and using the 2D angiography was still a primitive way, and it was still a lot of luck and probably experience of the operator. But I think one comment which was important is that if people talk about, oh, my tactile sensation was important, I think these wires make it a point that this tactile sensation was not important. It was actually a skillful understanding of the anatomy and creating a path within the path, which is going to guide you to a successful PTCA. And this patient, this is how we used 2 wires which had exited, and the final wire got in through, and we completed the case. This was in 1997, came up a beautiful paper by Srivastav from around 40 patients, where they took segments of CTO from patients who had post-mortem specimens. And it is the first time that we learned that the proximal cap was made of various tissues, and a lot of it, that the proximal cap was very hard, the distal cap was softer, and there were lots of channels. These channels were either within the vessel architecture or sometimes outside the vessel architecture. And this helped us bringing new technologies like CT into the armamentarium of understanding. And here you can see micro CTs on the left and the CT coronary as we understand it on the right side with those images to help us plan these procedures. So then came the era of microcatheters and intravascular ultrasound. And microcatheters, actually, you can see the earlier microcatheters, the new microcatheters, and now we have even a few more which I've identified in the next slide. But the most important thing was, we are trying to use the microcatheter to be able to change wires, because you don't want to lose the gain that you have actually achieved while progressing into a CTO case. And therefore, the microcatheters helped transit wires from one to another. At the same time, the intravascular ultrasound was an important addition to the tool in the antegrade approach, with a short beacon of a IVUS catheter with a very small dead space. It was easy to identify the true lumen, which is the yellow circle, from the false lumen in which the catheter lay. And therefore, now it was a new wisdom to this entire truth, where we were able to identify a vessel within a body of lumen which we had created, which was false. And this helped us negotiate. And I think this came in from Nagoya, Japan, which helped us to identify a path within the path, which was important. And so even though, and this was coupled with an understanding which was paved the way for future wire negotiations. These were the other microcatheters or channel dilators, as we may call, that are in clinical use. And I think it's important that most of them have specific properties, but they're basically very simple catheters, like the fine cross that we all use on the left side, to a threaded delivery like a turnpike gold, which actually is for the calcium, but the turnpike spiral and the mamba or the antegrade, there's a play between profile, lubricity, tapering of the nose, and how the tips are designed and how the catheters are designed. And it basically talks about torquing as well as transmission of force in penetration. We all know this slide from before. So people actually went and stepped up their wires, one step and a second step, and some went directly to what was a very, very tough wire from their initial, after having understood it. But the whole idea of the CTO and why do we need wires is because the CTO has an artery which is normal at one end. It is normal probably at the other end. And the two ends are matched with gates and doors on either side, which are the proximal and the distal cap. And both the proximal cap is typically hard or hardened in the chronic total occlusions. But as the age of the CTO increases, the distal cap also becomes fibrotic and calcified. And this increases the challenges of exiting into a true lumen by the pure antegrade approach. The body of the CTO was another issue. Not all bodies are straight, not all arteries are straight, not all lumens within those arteries are straight. And so came in, the success rates anyway changed, and they were approaching close to 90% in Japan. And I think the Fielder XTR family, which is the game changer, was these wires which had a dual, which had not only a slip coat, but there was poor transmission and handling because of low penetration. I mean, you can see this. We went in with a Fielder XT in this patient, and we had to change for a stiffer wire as we went around and complete the case. So At that time, in 2015, our approach was around 2015-16. We had the Fielder XT, Fine Cross Corsair, and we went to either this or we went to the Ultimate 3 or the Miracle Brothers. And if at all it didn't work, subintimal, we didn't have IBIS at that time, it was aspirational, but a parallel wire, which was a blinded technique. And of course, retrograde approach started in our practice around 2008, 2009 is when we started it. And this went on over the next few years. And gradually, we relied more on the retrograde approach to complete the procedure, taking into account the distal cap was softer, so it was more likely to get us into the luminal space. Of course, wire technologies, this has been discussed in length yesterday, and I'm not going to stick to this, but an important thing was the XTR. We suddenly decided that besides penetration and flexibility, deflection was an important thing. Torque control without a whip, that means a 1:1 torque without a whip, was important, very, very important for a good for penetration. And linearity of the torque to eliminate the whip was important. And I think the new design of the Actone, which we designed, was actually truly one of the first concepts which actually met all these needs. The philosophy had changed now, and the whole idea was to remain within the layers and within the vessel architecture for whichever approach you adopt, whether you have an antigrade approach or you have a retrograde approach. It was basically a loose areolar tracking, and so you find the path of least resistance, and in that path, the assumption was that the wire path is parallel to the wall of the artery, and most of us thought that this is what it was. So we thought that if we just took in a very stiff wire, we are just going to go and path through. But most of the times, the path within the artery was not as straight, and the actual path which would allow you penetration was often tortuous. And therefore, it was important that we went into areas, and you need these deflected wires. Wires had to be redeflected and be able to come into of wires which came in with increasing. Though here, the tip cross-sectional areas were gone down. However, the tip loads were small. They were tapered wires, but the penetrative ability of this wire per square inch of the surface area was not lost. And I think it is important to know that these wires brought in a different concept. And the concept over here was, this was one of those exemplary cases, an LED CTO torches. We started off with the Fielder XTR. We changed for a Gaia first. We made some progress. We then had that inner false lumen. We kept another wire in the false lumen, and then we brought in that Gaia to kind of complete the case as a parallel wire. And here we realized that the wire was easily maneuverable through a CTO body, and if we could target the lumen of the artery, and if there was calcium at the borders, it helped in keeping it inside. But in absence of calcium, it again remained a kind of a blind technique. For this deflection to work, we required a solid CTO body and a torque control. The handling was unique. So instead of the drilling was stopped. You don't drill with this because you can create a potential space which will neutralize the ability of the wire. And we talked about this yesterday. If the position is not acceptable, leave the wire, restart with the second wire using the parallel technique. My strategies changed. We started using the Fielder XTR and RA with various microcatheters, and in this period we started using either the Gaia second or the Gaia third at the Congress Pro, and of course the rest of them remained the same. IVUS was still a little, we don't have IVUS with a short dead space. The current IVUSs that we had were with a long dead space of 20 millimeters. They were not practical in the CTO anti-grade approach. And this was some of our cases that we did. This is a recent case reflecting of our current practice. This is a CTO segment. We get this simultaneous angiogram. What would be the approach? I think it is important to see the proximal cap had a side branch, so it is important sometimes to be able to have a very soft wire to find it. If this branch is too small to house a IVUS catheter to see the cap, but I think what is important is the distal part. It is diseased. So we know that our wires cannot be the ones like Conquest Pro and things. So we start with a soft wire. Once we made some headway, we realized that the soft wire was not able to turn around. We had to take a right angle bend. So it is important to leave those soft wires over there. The second was either you take a second Fielder XTR, but it is too soft and the tip does not have the control within the CTO segment. And so for me, it was important to take a second wire, which was not very penetrative. And so my second choice was take Ultimate Bro 3, which actually successfully was maneuvered into this. And again, now this is another case which we did recently. This is a right coronary artery, an 80-year-old whose PCI we did 20 years ago. He was okay for 20 years, but became unstable because of this RCA CTO and a circumflex lesion, long segment. You can see again the side, a major side branch, not able to house an IVUS catheter to understand the cap for penetration. So we went in. We first tried with this is a run-through wire. A run-through went in a millimeter, so indicating that there was a soft entry into it, and this is important, that if you can use a soft wire to enter the cap, nothing like it, so you're very likely to be in the loose areolar tissue. From then on, it becomes simple. We changed to an UB3. We went to a certain point, and beyond that, we had a choice between a Gaia and a Conquest Pro. And then I thought it's a straight course. So for me, this straight course was a Conquest Pro, which then went successfully. And then the next challenge was getting anything beyond into the wire. No balloons would track, so we used a Guidezilla with a Tornus. And this Tornus then allowed me to change to a normal routine run-through wire, which then completed the case. So our current strategy is Fielder, XTA, we have a choice of wires between many choices, and we use these choices interchangeably. There's a parallel wire technique, which is a second UB3 wire, IVUS guidance. And of course, there's also the third technique of a knuckle wire with re-entry, which I'll leave Arun to speak about it, at some stage. But this is how we've evolved, and thank you for listening. Atul, are you there?
Yeah.
Okay.
I think that was a great introduction to the topic, and I think Kirti, you can take over now, and you can introduce Asim, and he will.
Of course. So Asim needs no introduction to anybody who's been in the space. Asim has been with Asahi for a very long time, an extremely knowledgeable individual. And if somebody doesn't understand wires, probably should invite Asim for a cup of coffee and understand what wires do and how they need to be used. I'm not going to take much time, Asim. This is your podium. Please tell us more about where Asahi is going with the wires, and what do we expect to get in the next year or two, and how will that change our practice? Yeah.
Thank you, Dr. Kirti Punamia. Thank you, all the doctors, and I would like to share my screen first. Can you see all?
Yes.
Yeah.
Freeze it and go into presentation mode. Yeah.
So, good morning, all. I am Ashim from Asahi Intech. Just a second. Yeah. So, the topic today I'm going to discuss about the CTO Guidewires and its properties. Dr. Atul requested me first to talk about the basic concepts of the Guidewire, and then followed by the CTO Guidewire new technology. So I have compartmentalized my total discussions in 3 points. One is the general Guidewire properties. Second is the new Xiontech technology. That is the buzzing word today's in the industry. Everybody would like to use the new generation Guidewire of the Asahi and other companies. So, and third one, we would like to discuss about the CTO Guidewire. What is the new technology? What is the newness and its properties? Now, before going to discuss about the CTO, we would like to discuss about the basic features of the Guidewire. I am sure many young junior doctors are here who would like to know the Guidewire internal basic features. So I would like to discuss about first. So I have segregated these Guidewires into 3 parts. One is the distal tip, one is a core, and another is a coating. That when you talk about the distal tip, we always talk about the tip load, spring coil, tapering, and the coating. So these are very, very important part which plays a very important role for the success of any guidewire crossing. Second one is a core. The core determines the thickness. If the thickness goes up or thickness goes down, the core changes. At the same time, the material of the guidewire is also very important, the core material. Many companies having a nitinol, many companies having a stainless steel. People say that stainless steel is better. Some people say nitinol is better. It depends on the situation, what is your objective of the guidewire. Then the smooth or abrupt changes of the tapering. So tapering also very important for the success of the PCI. And then coating. Many operators I have seen that they are using the guidewire, but probably that depends on the technicians. So they are not totally aware about the coating. And there are different permutations and combinations of coating in the industry. Coming back to the first, coming from the down, one is a hydrophobic. That is a silicone coating. So the tactile feedback is highest in the hydrophobic coating. And then second is hybrid. Hybrid means the hydrophilic coating on the spring coil with a silicone tip. The tip is silicone, but the rest of the body is hydrophilic. The third option is hydrophilic on the spring coil with an uncoated tip. So look at example of, let's say for example, Grand Slam. Look at example of UB3. So these are all the uncoated tip with the hydrophilic. Then hydrophilic on the spring coil. And then finally, the most lubricious guidewire in the industry is hydrophilic with a polymer jacket. So polymer, once we see the hydrophilic coating, sometimes there are some uneven pores in the guidewire. So because of that, hydrophilic coating is not able to cross the tortuous lesions. So that's why there is a reason of the polymer jacket. So polymer coating makes the guidewire more smoother. So this is the basic building blocks of the guidewire. So I will request all the doctors, the junior doctors, please understand this. This is very important. Now, this is very, very important for the understanding the coating. Irrespective of any company, whether it is Asahi or whether it is any other company, there are three kinds of coating technologies there existing in the market. One is a silicone coating. And the silicone coating comes from the hydrophobic coating. So this has the highest tactile feedback, but the lowest lubricious. So it is basically good for the the doctors who expect more tactile feedback. So example is Grand Slam, Miracle Series, Intermediate. Then coming back to the slip coat coating, it basically talks about the hydrophilic coating. So hydrophilic coating gives you better trackability and more smoothing of the guidewire because of the hydrophilic coating. So for example, Renato Conquest Pro, even we have launched recently Gaia series, you have seen. So Gaia series is also hydrophilic coating. Then comes to the slip coat coating, that is the maximum lubricious because of the polymer jacket coating. So please understand, without hydrophilic, polymer jacket cannot be given. It's like, wearing a jacket without t-shirt, it cannot possible. Most of the people having the jacket with the t-shirt. So t-shirt is hydrophilic and the polymer is basically the jacket. So the example of the slip coat coating is Fielder FC, Fielder XT, Fielder XTA, Fielder XTR. All these are all polymer jacket coating. So this is the picture which shows the smoothing of the guidewire. So if you go from the silicone coating to the polymer jacket, the smoothing part increases. So the uneven pores part of the guidewires is basically off. So if the doctors wants to cross any tortuous lesions, if the doctor wants to cross any bending, the best is polymer jacket guidewire. So now this is one slide which talks about the lubricity and the tactile feedback. As I already discussed, this is disproportionate. Lubricity goes up, tactile feedback goes down. So this is self-explanatory. If you go from the spring coil hydrophobic to the polymer jacket, the lubricity goes up, but you are compromising the tactile feedback. So it depends on the case to case, which guidewire you actually want. So now many people talk about the tip stiffness, but who gives the stiffness? From where the stiffness comes? Let's say talk about the software and the stiffware. If you see the inner core of the guidewire, so when you talk about the software, let's say talk about the Xion Blue, let's say talk about the Renato. So in that case, the thinner core is very thin because it is soft, because it is very, very flexible. But if you use the stiffware, the core of the core wear, the diameter of the core wear goes up. So because of that, you get the more stiffness, you get more support. So this is also very, very interesting slide. Recently, we have launched the Suo 03 in the industry. From the Suo, if you go up, the tip load goes up. So, in India now we have Conquest Pro 820 also. This is 20 gram. In Japan, we have a 40 gram tip load. So the tip load goes up from the low to the up. Now many people thinks, many people says, this wire has a very good support. Many people say, no, this wire doesn't have a good support. But from actually where the support comes, this we need to understand. The support comes from the core diameter. This is very, very important to understand. So if the core diameter of the wire goes up, look at example of Grand Slam or look at example of All Star. Even we have launched recently Xion Blue extra support, even the Fielder FC. So these are all the core diameter is very high. So let's say if you see about the Grand Slam core diameter is 4.5 centimeter. Whereas if you see the Xion Blue core diameter is 20 centimeters, so 20 millimeters. So the changes, so diameter changes, support changes. So the diameter is very, very important to understand the support of the guide wire. Now there are another two terminologies which you always talk, that is, the torque is good, your company's torque is very bad. So torque is very, very important role in crossing the the PCI or the CTO lesions. So when you talk about the torque, there are two terminologies we need to understand. One is the torque response, another is the torque force. Now let's discuss about the torque response first. So torque response is basically the capability of the guide wire tip movement without any delay. So as Dr. Kirti Punami already discussed, is 1:1 torque, which is very, very important to understand. So there is a phenomenal changes after launching of the Gaia series and the Xion Blue. Earlier we were compromising our guide wire. There was a torque delay. Now then coming for the torque force. This is basically the power to rotate the guide wire even if it is restricted. So in case of the CTO lesion, our torque force and the torque response goes up, or the demand of the torque response and the torque force is very, very high. Now often we talk about the trackability and the torque force, and these two are disproportionate. If the trackability goes up, torque force goes down. But there is a need also trackability. There is a need of the torque force. So you can't expect that everything is trackable, everything is torque force. So if you expect more trackable guide wire, you are compromising the torque force. Another way, if you are expecting more torque force, you are losing your trackability. So there should be a trade-off in between this. So we need a better solution in the industry, which gives a very good trackable, at the same time the torque force also goes up. So that's why, before going into the new technology, I thought let's discuss also the core tapering, whether it is a round core or the conventional core. If you see the earlier century, people used to use the conventional flat core. But the flat core, the problem is the whip is very high. So if you want to go for the, let's say, side branch, the wire will not go to the side branch, wire may go to the main branch. So these are all very bothering for the doctors. So that's why there is a need of the round core, which avoid the whipping phenomenon. At the same time, better maneuverability even in the complex vessel anatomy. Now with this, so many problems in the earlier generation of the guide wire, there is a new generation technology which has a paradigm shift of the guide wire industry and the guide wire technology. So name of the technology is called the Xiontech. It has been introduced by Asahi, and the technology, there are a lot of confusions in the market. People use it Xion Blue, people use it Gaia, but they are not totally the clarity is not there. Actually, from where the the benefit comes, from where the changes is happening. So the new technology is called the difficulty is called the Act 1. So the applying the Asahi unique wire forming technology, drawing technology, and the torque technology, we developed the multi-wire coil. It gives the enhanced torque force, torque response, durability, and the flexibility. So let's discuss one by one. What about the Act 1? What is all about the other names? If you see the guide wire, I will come to the picture first. This is very interesting slide. This is the core. This is the core material of the guide wire. You can see the inside core, and outside there is a spring coil. Now, core may be flat core may be round core. So if you see the flat core, we are compromising the whipping. So that means whipping is more. So that's why there is a need of the round core. So round core gives a better torque response and the no whip motion. Now, if there is no core, nothing protecting core, only the core wire torquing. So that's why we need a durable part in the distal part of the guide wire. So that's why we have introduced a technology called Act1. So Act1 is nothing but a multi-wear coil. Multi-wear coil, like you can see the spring coil. Inside the spring coil, there is a one more coil. So the benefit of this coil, which makes the wear more durable in the distal part. Sometimes you have seen the wear becomes kinked, but nowadays, after introduction of the Gaia series, the kinking chances has gone down. Even if you go for the mild to moderate calcified lesions, it's because of this Act1 technology. So the technology of the Act1 makes the guide wire more rigid, more strong, more durable. And at the same time, because of the Act1, the torque response is very, very high. Now you will be very shocked to see how many guide wires are in the Xion guide wire. Just see in the core material, just see Xion is 014 guide wire, but in the 014 guide wire, there are 15 wires in total together. Core is 1, spring coil is 1, Act1 is 6 wires in the multi-wire coil, and there is a twist wire. So I will explain the twist wire. What is twist wire? Twist wire is basically the parallel of the core wire at the distal tip. So the objective of the twist wire gives the more tensile strength and wire becomes more flexible. So if you see the Gaia, there is no twist wire. Gaia, there is no twist wire. But if you see the Xion, Xion blue, Xion black, there is a twist wire. So this slide is very, very interesting. Now please understand that I have segregated the two parts. One is the normal wire, single wire, another is a rope wire. So if you see the single wire, there are two parts of the wire. One is a single wire coil. So you can make a one wire, make a coil. You can make a multi-wire coil, means same wire, but you are making multi-wire. So the construction of the Xion, Gaia, Schwilder XT, A and R, these are all made up with a multi-wire coil. So if somebody asks you, the junior doctors I am talking, what is Gaia made of? You can discuss definitely with the other doctors that Gaia is made up with a multi-wire coil. And it is made up with the Act1. So the Act1 makes the Gaia more strong and more torque response. And coming back to the wire rope coil, there are two parts. One is a single wire rope coil, another is a multi-wire rope coil. You must have heard about the name called Gaia Next. So Gaia Next is coming very soon. People are waiting passionately when the Gaia Next is coming. So Gaia Next is made up with a multi-wire strand coil. So the Gaia is made up with a multi-wire coil, whereas Gaia Next is made up with a multi-wire rope coil. So there is a big difference of the internal technology of the Gaia and Gaia Next. You are seeing only the tip load and the external specification, but the internal technology makes a lot of difference. Now coming back to the fourth technology, one is a single wire coil, one is a multi-wire coil, one is a single wire rope coil, another is a multi-wire rope coil. So far, Asahi's technology based on multi-wire coil. Please understand the Act1 technology based on multi-wire coil, not the single wire coil. And the Gaia is coming up with a multi-wire rope coil, that is an extra technology. So when you see about the multi-wire coil, you know the need of the wear changes depends on the lesion characteristics. So when you talk about the Act1, when you talk about the multi-wire coil, the flexibility you are compromising. You don't need a much flexible wear when you go for the CTO cases. You need a more torque response. So the torque is very high when you use the Gaia. You must have realized. Similarly, but you know, sometimes the wear doesn't go into the little bit calcified lesions. Many people say that, you know, Gaia doesn't move. I have used in calcified lesion. But please understand, the Gaia is not meant for the heavy calcified lesion. Gaia is meant for the mild to moderate calcified lesion because the Gaia tip load is not high. So that's the reason there is a need of the change of the technical aspects of the Gaia. So we have introduced Gaia Next. So Gaia Next gives a better flexibility, at the same time the torque. So we have compromised little bit torque, but not too much. But at the same time, we have increased the flexibility, so the prolapse chance goes down with the Gaia Next. Now with this all the words, I'm not going to introduce the Asahi's composite guide wire, which has given a paradigm shift in the industry. The success rate of the CTO has gone up. Is because of this technology. So it is really, I'm very unfortunate today that Dr. Atul has given Asahi to give this talk. So people will come to know what is all about the new generation technology. So the guide wire that is composed of more than core wire and the outer coil. If you see the earlier generation, doctors used to compromise about the the flexibility, about the torque response. So similarly, after the introduction of the composite guide wire, not only the core wire, not only the outer coil, we have introduced the Act 1 technology. We have used the multi-wire coil that enhanced the success of the CTO industry. Now coming back to the couple of basic features we would like to share. If you compare with the single wire coil and the single wire rope coil, the flexibility in the, you can use your common sense. The single wire rope coil goes up compared to the single wire coil. So that's why Gaia and all other new generation guide wire is made up with a single wire rope coil, not the single wire coil. Now you can see some video. If you see the conventional wire, people used to say also that, you know, the rotation was good, but you see the rotation. You see, the rotation is not very smooth. But if you see the multi-wire Act 1 technology coil, look at Gaia, it is very, very smooth. So the smooth torque response is very, very important for the success of any complex cases. Now, this is the inner constructions of the Act 1 technology or the Shiontech technology of Asahi. The blue color, you can see the Act 1. The Act 1, you can ask me, what is Act 1? Act 1 is nothing but a multi-wire rope coil. There are multi-wire coil that is roped up outside the core wire. The blue color signifies the multi-wire rope coil, that is an Act 1. You can see the core wire, and the parallel of the core wire, you can see the highlight of the red color, there is a twist wire. So the twist wire is not available in everywhere in Asahi new generation. Please understand, this is very important. The twist wire is only available some specific wire, like a Suo, like a Shion, like a Shion Blue, where you need more flexibility, where you need more tensile strength, where will not kink. Let's say people are using in the septal lesion for the Suo 03, where should not kink, although the tip load is 0.3 gram. So you can see the difference between the single wire and the wire rope coil. The wire rope coil is more tensile strength, and the flexibility is also high. Now let's have a quick look at the Suo 03. Suo 03 having the rope coil, and if you see the XT and XTR also single wire outer coil. So both are having the Shiontech technology with the Act 1 core. But the Gaia Next is totally different. Please understand. The Gaia Next, I will come back here. Everywhere is a single ball. You can see every coil there is a single ball. But if you see the Gaia Next, every coil there is a multi-wire coil. So in a single wire there is a multi-wire coil, multi-wire rope coil. In case of Gaia, there is only one rope coil. But in case of Gaia Next, there is a multi-wire rope coil. So that makes the wire more strong. So even if you use the 2 gram of Gaia Next fast in the calcified lesion, mild to moderate, it will not prolapse. That's the reason the success rate of the CTO has gone up even in Japan because of after Gaia Next launch. So I'm sure you people are waiting for the Gaia Next. It will come very soon. Now let's have a look of the Shion, Shion Blue, Shion Black and Suo 03. You can see the twist wire is missing. The twist wire is there. Act 1 is there. But the conventional wire Act 1 is not there, twist wire is not there. But if you see the Gaia series, Gaia Next, Fielder XTA, Fielder XTR, Shion Blue ES, Act 1 is there, but there is no twist wire. So please understand, this is very, very important. Shion, Shion Blue, Shion Black, Suo 03, twist wire and Act 1 both are there. But in case of the Act 1 and twist wire, for Gaia series is not there. Fielder series is not there. So there is a need of the twist wire because the twist wire makes the wire more flexible, and at the same time the tensile strength goes up. It is more of a routine wire. Now coming back to the CTO products, so far we have discussed all about the technical aspects of Asahi and at the same time some kind of the basic understanding of the guide wire. Now we will discuss about the CTO products. Now we have launched so many products in the market from the Fielder XTR. I'm not talking about the earlier generations, mostly in the Fielder XTR, Fielder XTA, Gaia series. Then earlier we had a Confianza, Miracle. So the tip load goes up from the Fielder XTR to the Conquest Pro 12. And then Fielder XT has been extended to Fielder XT A and R. So there is a need of the Fielder XT A and R. First of all, Fielder XT, if you see the polymer jacket guide wire, but the problem is the tortuosity, the torque response is not very high. Although it is a tapered wire, but the torque response within the micro channels is not there. So there is a need of the higher torque response in the market. So that's why we launched Fielder. This is the 0.8 gram tip load. So you can see the software without Siontech, low torque force, durability and the shape retention are relatively poor. But in India, many doctors are using Fielder XT. So we all suggest you please upgrade yourself from the Fielder XT to Fielder XT-A and Fielder XT-R. So you should know where to use Fielder XT-A and where to use Fielder XT-R. Fielder XT-A used for the crossability. So if any junior doctors who would like to start their CTO program, they can start with the Fielder XT-A because the tip load is 1 gram. It is not like a Gaia or maybe Conquest Pro. And then if people wants to track the thing within the micro channels, then the best is Fielder XT-R because the tip load is very low, just a 0.6 gram, and the tapering is 0.010. So we would like to suggest doctors please use Fielder XT-R and Fielder XT-A. Even people are using Fielder XT-R for the retrograde. Now coming back to the Fielder XT-R, these are people use for the subtotal occlusions, for the first choice of CTO Guidewire for the channel tracking and the retrograde navigation. Whether it is a stamp or without stamp, people are using it, Fielder XT-R. Now Fielder XT-R is same like a category of the Fielder XT, which is a polymer jacket, highly lubricious, extreme tortuosity and tight lesions you can use Fielder XT-R. It is good for the micro channels, less likely to damage because of the tip load is very high, and it is good for the collateral channel tracking. Now coming back to the Fielder XT-A, it is also made up with the new generation technology Siontech. It is the first choice of CTO Guidewire for active soft tissue sliding. So it may be stamped, it may be without stamp. Risk is little bit low compared to the other high tip load Guidewires because just a 1 gram tip load you can try with the Fielder XT-A. So this is all about Fielder XT-A 1 gram tip load. Now Dr. Kirti Punamaya was talking more into the UB3 because this is really a very good Guidewire in India. Very few doctors are using Ultimate Pro 3. It is a very good Guidewire. You can try with the Ultimate Pro 3. It's a hydrophilic Guidewire. The difference between Miracle and hydrophilic, Miracle is a hydrophobic Guidewire and the Ultimate Pro 3 is a hydrophilic Guidewire. Tip load is 3 gram. It is very good for moderately calcified lesions with tough tissue. So uncoated tip with a hydrophilic coating. You will get the tactile feedback and the lesion entry because it is not a polymer jacket Guidewire. Now coming back to the Gaia series, people by the time most of the doctors in India, they have tried Gaia and it is phenomenally good. They have got the success. So Gaia is basically available, Gaia first, second and Gaia third. So what is the newness of the Gaia? Dr. Mehta will talk in detail about the Gaia and other success stories, but I would like to just features about the properties because my topic is properties. If you see the conventional Guidewire, the conventional Guidewire tip is a round core. But if you see the Gaia is a microcone tip. So when you have a microcone tip, the penetration force also goes up. So let's say if look at example of the Conquest Pro normal is 9 gram or 12 is 12 gram, but the tip load is very high. But in case of the Gaia, 1.7 gram tip load is equivalent to the Miracle 3 gram. So you are using the lower tip load, but you are expecting the higher penetration force. It's because of one of the reason is the microcone tip of the Gaia. This is a newness. At the same time, the other CTO Guidewires you have seen, it is a straight tip. It is not J tip. But in case of the Gaia, it is not a J tip or it is not a straight tip. It is a 1 millimeter 45-degree angle. It comes from the factory setting. Earlier, I was talking with some doctors. They were asking me why it is a 1 millimeter, why it is a 45-degree angle. There is a reason of that. So I will discuss after these few slides. So now when you have a microcone tip, it is 1 millimeter. It is easier to access the occluded lesions and possibility to create the new roots. Sometimes with the hand, it is very difficult to make the 1 millimeter or 45-degree angle. So that's why doctors have, from the factory setting, it has come. Now, when you talk about the conventional Guidewire, it has a ball tips, cannot reach the entry point of the lesion. But the Asahi Guide hydrophobic microcone tip, it catches the entry and possibility to create the new root. Now, 1 millimeter pre-shape, the most distal tip is shaping during the production, saving the operator the difficulty at the time of manual shaping. Sometimes it's very difficult to make the 1 millimeter shape. You can always provide the second degree curve. Possible to increase the angle to create a more acute curve manually. Possible to reshape the tip depending on the procedural conditions. So the tip shape, you can see the small tip shape. Then you can make the deflection with the second. Then you can make a large tip shape. So it depends on the situation. You can make your tip shape changes, but the 1 millimeter is there always in the Gaia. Shape retention is very high. It is because of the Shiontech technology of the Gaia. You will never lose your tip shape. So when you talk about the conventional guide wire, whip motion is very high. Control of the guide wire with you is not there. But when you check about the Gaia, it has an enhanced torque response and whip motion is almost zero. So the control is come. So if where the success comes from the Shiontech. That is the technology. Now you can see two video. One is the conventional. The torque response is very low, but if you see the Asahi Gaia, torque is very, very enhanced. Now this is the software at the ostial lesion and the bifurcation. Sometimes it prolapse, cannot enter the lesion. Stiff wires will enter the straight wire and the possibility to vessel damage. So when you use the stiff wire, it can damage the vessel. So when use the Asahi Gaia third for the ostial lesion or at the bifurcation.
Asim, may I request you to try and conclude, because you know we're already past 12 and we still have a couple of talks.
Sure.
And
I will.
Yeah. Okay. Great. Thanks.
So this is the success of the Gaia with lesser tip load. Now I am coming for the interest of the time. I am coming the Confianza Pro 9 gram tip load. Then coming the Suo 03. I thought we will discuss the Suo 03. This is very interesting slide. The Suo 03, there are so many wires. You can see total 19 wires in Suo 03. Twist wire is also there, 7 wires. So I'm just keeping these slides. Suo 03. Then Xion Black. People are using Xion Black also sometime. And so I would like to conclude my session with the introduction of the two new guide wires in the industry. People are using, waiting for the Mongo Gladius MG. In US, there is a guide wire called Mongo, which is for the knuckling. So it is coming soon in the month of February 2021. That is 014 guide wire, polymer jacket, and also the Gladius MG ES. So name of the Mongo is in US, but in India or in Asia, it is MG. And then this is a Gaia Next 2 gram, 4 gram, 6 gram. These are also coming very soon. And I would like to conclude the session with a small 1-minute video. Thank you so much, all.
Thank you.
Thank you.
Kirti, BC, you want to?
Yeah,
Sorry, that was a great talk, but time constraints. So, Atul, any questions up to this point, or should we
I
go
think
ahead?
we are running a bit late, so I think let's
get
go ahead with the
let's
talk.
get Sir to get on his talk. Yeah.
Yeah.
Dr. Mehta, you want to come into the talk?
Okay. Am I audible clearly?
Very well, sir.
Right. Good. So just
A little higher on volume, sir, might help.
all right. Better.
Yes, sir.
Yeah. Yes.
Okay. All right. Kirti and Atul, and even VC for that matter, you people are my investment, and I'm so happy to see that the investment is growing exponentially. So it gives me an immense pleasure to participate in this debate. You know, when you are a middle rank batsman or the last tail ender batsman, there are certain problems. I remember when Dr. Subramaniam from Lenox Hill Hospital had come to give a talk here, and his flight was late and his talk was being shifted. Then he was told that your talk will be now for 30 minutes, Subramaniam. Then the previous speaker started delaying, and therefore Subramaniam's talk is 20 minutes. And then it came, Subramaniam, there's no time. It will be taken as in being read, but it will not be read. So fortunately, I'm not in that plane. You know, very interesting, Asim. You gave a lot of details about the wire. I've been driving the car right from the age of 18 until about only 2 years ago. I did not know that the modern cars don't have carburetor, it's a fuel jet. So it's very important that I never open the bonnet. I just keep on driving, but I'm not a bad driver, though I don't know about the car. And so Asim, it's very nice that you informed me about the carburetor. Now I'll drive it a little better. And sometimes if I'm stranded, I will open the bonnet. Okay, never mind. The other thing is that it's unfortunate that there has been debate still going on whether the CTO should be opened or not opened, and that I think it's gone past the time now that we all know that if there is a viable tissue and that is being supplied by a CTO, we must open and we must learn, how to do this. And I'm told that there are about 5 to 6 lakhs of angioplasty performed every year, and out of which, if I count for 1%, then I think about at least 5,000 angioplasties should be CTO angioplasties, but that is not so. The penetration is still very low, and therefore the people, lots of people are still at a learning curve. So to show a very complex case to them would be a useless acrobat, which I don't want to do, and therefore let me talk to their wavelength. And here is the beginning. Look at this. The aim is, as like Dr. Kirti Punania told us, that from the proximal segment, which is a patent segment, to a distal segment, we have to traverse through the proximal fibrous gap, then we have to travel through the missing segment, and then we have to travel and enter the distal fibrous gap and then enter the true lumen. That's it. Now in the middle, whether you are in a true lumen or a false lumen, you will not even come to know. You may be true and false, or you may be true, or you may be totally false. What matters is that you must enter the distal fibrous cap and then enter into the true lumen, and that's a goal. Why so? Because after the wire success, the procedure success rate is 97.8%. So therefore, the wire is pivotal. You must achieve the wire success. And I think therefore success is in your hand. And I know very well that when I am trying to cross a wire in a very tough, long, tortuous, calcified, missing segment, and the people are sweating in the cath lab and people are eagerly waiting that it cross, and when they cross the distal segment in a true Lumen, there is an orgasmic ecstasy. Everybody is so happy and plays and there are claps and whatnot because the success is already done. Success is in your hand now. All right. This slide has already been done. But I just want to show you one thing. Do not talk in terms of a tip load. Do not talk in terms of lubricity. To talk in the penetrating efficiency. The penetrating efficiency is the conglomeration of three factors. One, tip load, of course. Tip size, the tip surface. And thirdly, tip lubricity or the tip coating. These three combined together will make a penetrating efficiency. To give you a classic example, Miracle 12, you see here, is penetrating force is 70, but the contrast probe for identical tip load of 12, penetrating efficiency is almost double. Why so? Because of other qualities. Its ability, for example, the tip of the contrast probe is uncoated and it's a small 0.009, and therefore this is a 0.0010, but much smaller than this is 1.014. So that makes the difference. Lot has been told about it, so I would not repeat it. One more difficulty when you are a middle rank batsman, that constantly you have to reshuffle your thoughts because you do not want to repeat what the others have already said, and your talk includes what they have already said. So you have to reshuffle in your mind, and that I think is a much more difficult task than doing a CTO sometimes. The proximal cap, if it's visible channel, 1 minute. Huh? Yes, I will skip this slide about which I think so many hints have been given. So let's go to the never use a dedicated wire without reaching the platform. There have been, why am I saying this is that, see, the dedicated wires have a special property. They're not meant to travel through the proximal normal segment. And secondly, the shape that you give is also very different. And in case if you dissect the proximal segment, your day is done and you'll have to call it off because thereafter you have a different problems. So please never use a dedicated wire without reaching the platform. And let me now talk about it. The tapered proximal cap leads to a microchannel, practically always. If you carefully see here, you can see that there is a microchannel, a visible microchannel. Whenever you have a visible microchannel with a tapered tip, or even not visible microchannel, but the tapered tip itself usually leads to a microchannel, and the polymer jacketed low tip load wire usually works. In this case, we talked about the wire like polymer jacketed filter XTA, filter XTR, and so on. One more thing which I want to tell Asim, and that is what is missing from Asahi, is this, that your polymer jacketed wires do not have tip loads. They are either 0.8 or at the most 1.1 in the, but now, for example, Pilot wire is also a polymer jacketed wire, but the Pilot 150 can give you a tip load of 3.5, and Pilot 200 can give you a tip load of 4.5 and 6. Combined with that tip load, Pilot wire has a special niche. You can use in some situations where everything else would fail, but the Pilot will be very handy, very successful wire. Anyway, now, why the guide wire should always be supported by microcatheters? Dr. Kirti Punana touched that point, but I will elaborate it. Facilitate guide wire exchange in the coronary artery lumen during PCI. It stabilizes the guide wire and reduces the risk of it entering into the subintimal space. Can also straighten the proximal curve or a tortuous coronary artery and before beginning the CTO, and it increases the guide wire torque so that it is close to 1:1. And when the wire is alone, then you know that it is likely to wobble, and then it is likely to get bent, it can create trauma, and it can go in the wrong direction. And this is if you have in the smaller, the lower diagram are shown that if it's a microcatheter, the wobbling is much less. And what are these microcatheters? We did not discuss so far about them, but they are crucial. Why? Ultimately, wire success. Ultimately, the wire must cross. With what you are doing it, what are the supports, etc. You should be familiar with that. Currently, we have a 1, 2, 3, 4, and 5. Sasuke has still not reached the shore of India. Therefore, 1, 2, 3, and 4 we will talk about. Well, the most commonly used microcatheter in my laboratory are fine cross and Caravel. Fine cross has an entry profile which is very helpful. 1.8 French, 0.6 millimeter, and then over entire length, 1.8 French spreads over to 2.6 French, and that's why it's a very sleek, very nice product. And at the same time, I can talk about Corsair. The Corsair also has a tapered soft tip, and it's tungsten coated, so it gives a radio opacity, and it is a Shinka technology, and it's hydrophilic coated, and then its profiles are even smaller than fine cross. Fine cross, if you go into detail, the entry profile is 1.8, 0.60, and the distal profile is 2.6 French, and therefore proximal profile is 2.6 French, and the recommended Guidewire is 0.014, and surely you can use a smaller one, no problem. And talking about the Caravel, it has a profile even better than even fine cross, and its profile is 1.4 is contrast to 1.6, and so on and so forth. So you can interchangeably use this. The times come, there are times when we are doing a retrograde catheter, retrograde procedure, retrograde approach. We find that sometimes the fine cross works and the Caravel does not work, or sometimes the Caravel works and the fine cross. There are certain times there are fatigue, the fatigue of the hardware, and then sometimes changing from one Caravel to another Caravel works. All right. So then, important point is Caravel was designed for pushing and not spinning. It is in contrast to Corsair, and therefore if you do Caravel and start spinning it, then you might damage it. Okay. Now there are 3 techniques of wiring: drilling, penetration, and sliding. And I cannot say when to do penetration, when to do drilling, and when to do sliding. Sliding, yes, I can easily say that when there is a polymer jacketed wire and a micro channel, then it slides through, and it's easy. It's easy. It's the very simplest of all the CTOs is one which has a micro channel, and use a polymer wire, and you will be able to cross the distal segment. The drilling and penetration is combination. Sometimes in the same patient, you might drill for a while, and then sometimes in the same patient, you apply a force and penetrate, so on and so forth. Let us see now the case-wise illustration. This is the case which has received the stent previously, several years ago. And look at the right coronary artery. Totally diseased right from the origin. And ragged looking, irregular kind of a disease, and the channel is so very irregular that you might have tough time to negotiate through that channel. And it's a very large artery, because on the second injection from the contralateral side, you see that the right coronary is very huge, big, and this patient had an ischemia. Prima facie, we would like to do a retrograde technique to start with straight away. Well, maybe, maybe not, because the segment that you are going to cross is a very long missing segment, almost 90 centimeter, and therefore this is a difficult, very difficult CTO. But unfortunately, there were no connections, no suitable connections to apply the art of retrograde. So let us see now what we have to do. All right. To start with, it was with the Fielder XTA and the fine cross. And it went to some length. You can see here that I made a very small curve. And why just such a small curve? Because I knew that this wire will have to torque a lot through tortuous channel, whatever is visible. And then I got stuck. I got stuck at some point, and therefore, let's see. And I said, I think I'm not traversing through the right kind of channel, right pathway. And when I see another injection and to another view, and I find sure enough, I'm way outside. So therefore, this is very important that when the wire, you get stuck somewhere, make sure that you are in the correct channel, take multiple views, and then decide. Ultimately, after some time, bringing the microcatheter halfway, I changed over to Guidewire. And this Guidewire also has entered somewhere outside into the missing segment. And you come to know that you are outside the missing segment, outside into the false passage, only when you have opacified the distal segment. Till then, it does not matter. Till then also, and you cannot come to know even whether you are true or false or true and false, etc. It doesn't matter. We knew here. Now what do? We have 2 or 3 things that we can do. Maybe I'm in a small branch. I don't know. So we bring it back and torque it and trying to use another pathway and forward it. And you realize that you are still not very much within the lumen. And therefore, you bring it back, torque it again, or you can give another shape. And then the microcatheter travels all the way into the true lumen. Having brought microcatheter towards the terminal part, I make an injection through the microcatheter, and that injection shows that yes, we are in the true lumen. There may be a controversy whether one should inject or no. Well, to find out that you are in the correct lumen, and you can very confidently make an injection without creating a dissection, is this, that when you with the 2 cc syringe draw blood, and the blood flows back easily into your syringe, then in all probability you are in true lumen. Then why do we inject in that case? Well, sometimes you want to know the course of the distal vessel, and that is how you will come to know. And having done that, balloon dilatation, serially done. And you know very well that in this kind of cases, the long stent delivery is very difficult. So preempting that, I think one should consider taking the help of a guideliner or a guidezilla, as we have done in this particular case. And if the time permits, how to correctly use guidezilla, there are 2 or 3 ways you can do that, and that we could discuss in case the time permits us. And then this was, again, a second stent was brought in, and this is the injection and the final result. And you see there is a lesion in the distal artery. There is a lesion in the distal posterolateral branch, but when we gave a nitro, that lesion disappeared, so it was a spasm. No need to waste a stent there, no need to waste your efforts there, and this was a very gratifying result of a large in-stent stenosis. He received 2 stents, and finally we got a 4.5 millimeter artery supplying a large portion of myocardium. All right. The in-stent CTO is a very special CTO. The borders of the CTO are known. The advantage is that you know the borders, but the disadvantage is that when you enter behind the stent without your knowledge, because the wire has a good penetrating power and the tactile sensitivity transmitted to your finger and to your parietal lobe eventually is not very sufficient, then I think you may destroy the architecture of the entire artery. And the old CTOs are sometimes calcified and very hard and fibrotic. Okay, can you change the guidewire within the CTO from the lower to higher penetrating efficiency and vice versa? Yes, you should do it unhesitatingly. Incidentally, I also must tell you that having traversed through the missing segment, once in a while you should pull back. Why? In case if you find that there is a resistance to pull back, believe me, you are invariably in the false passage. And then I think when you file a tag that when you find a resistance, then I think it's caught into the web of a false passage, and you should come back and try to take another pathway. Well, here, so therefore we should, and then this is the case where there is an LAD, a blunt CTO at the level of septal and diagonal branches, and Fielder XT and Gaia 2, these 2 wires were used sequentially, and ultimately a shoot was made through the microcatheter. There is a fine curve. So the Gaia 2 was reshaped, and Asim, I know that there's a factory, it's a factory-made small curve, but you can make a secondary curve in Gaia, which I think many people believe that it can't be done, especially when I go as a proctor, we realize that they feel surprised when you try to make a Gaia a shape again or give a secondary shape. And that worked out, And then finally, this was the result. So the points that we learned is, yes, you should use Gaia whenever there is a need for it, especially when you think that there is a need for a torqueability, large, essentially a torqueability is needed. At that point of time, you can take your Guidewire and give it a shape if necessary. Now here is a CTO which has diagonal and the LAD CTO, where the LAD and the branch is practically a right angle. The missing segment of the LAD is arising at a right angle. In such a situation, the use of a Corsair, the multifunctional catheter, which has a 2 lumen, the terminal lumen is a monorail, and the proximal lumen, about 5 millimeter proximal, is over the wire. And an appropriate wire in this particular case, we had taken Fielder XTA wire, and this could be crossed. There was no way otherwise. This was a failed CTO at some other center, giving an appropriate small curve, almost to a tune of about 60 to 90 degrees. We could enter with the help of Crusade, we could enter the CTO, and finally, this was the result of the CTO. So again, it boils down to wire success. Talked about parallel wire, but I want to hint at you some few important points. First of all, when you use a second wire, first of all, why not change the direction? Yes, you can do 1 or 2 times. But if you repeatedly keep on entering the false passage, the false passage becomes larger and the true passage collapses, making the subsequent efforts much more difficult. Therefore, you should use the second wire, parallel wire, unhesitatingly. The important thing to remember, there are 3 important principles. You must enter the parallel wire. It should be entered from proximal to a point from where your first wire entered into the false passage. 2, it should have a little larger curve because it has to re-enter from the false to the true passage. And 3rd, it should be a little stronger. If the first one is, let's say, a 3.5 tip load, like Ultimate Brothers, or then you should like to use probably a 4.5 or a Miracle 6. And this is how it could work. And the manipulation should be such that finally the 2 wires must cross each other. Why it must cross each other? Because you are entering from false to true, and the first wire is in the false passage only. So now let us say, yes, second curve should be a little more acute, and the length of the secondary curve is a little longer, and the second wire is a little stronger. Let's see now how I used it. This was in ostial LAD, only a stump. Whenever there is no entry point and the blunt stump, what do? There are 1 or 2 things that you can do. You can do a side branch IVAS. Here is, you can see the side branch IVAS, and we can take the ramus which is arising as a point to be taken for an entry into the CTO, and that can be a marker for you. And so that, because we don't have always a co-registration with the IVAS and the angiography, then therefore these are the points which you should. Thirdly, whenever you find that the IVAS shows suddenly a large lumen, then you must understand that you have entered the polygon, and that is the confluent point, and that is the carina. And that is where that you know that yes, you are sure that there is a vicinity where the total occlusion would be, and you can manipulate wire in that particular direction. In this particular case, they used the Fielder XTA, Pilot 150, Pilot 200, parallel wire. You can see 2 wires together, and both the wires kept on going into the false passage. So having tried some time, and then not to damage it further, decided that all right, we leave this here, parallel wire with the Conquest Pro, and that also could not cross it. The wire in the ramus is only for a reference, and subsequently retrograde technique was attempted. And you see here the retrograde that it could not progress further. There was such a hard point at some point that I could not succeed retrogradely too. So then talked to the patient and brought him back to the cath lab again the next day morning. And this time CT was re-attempted. I tried Miracle 6 that went into the first passage. Then I took Conquest Pro, 2 of them, parallel wire technique, and both were Conquest Pro. and ultimately Conquest Pro succeeded, and this was subjected to IVUS examination, and after that this patient received the stent, and this was the final result. So the point is that Kirti might remember that when we had a workshop done at the Jaslok Hospital, Dr. Hiramat was attempting a totally occluded circumflex, and he had the first wire in the false passage, second wire also in the false passage. And then I went to help him, and then we used the third wire, and those two wires were kept in the false passage as it is, where they were, and the third wire, with the help of the two false passages, the two geographical maps, entered the third wire into a correct passage, and finally the successful, the CTO successfully cannulated. And here is the CTO of the RCA, and with an anomalous origin. When there is an anomalous origin, it's an extra stress because the backup support from the guide catheter is very often poor. And beyond mid part of the CTO, wire was not progressing, and I have taken not the Judkins curve. Judkins curve is hardly ever successful, so this is AR2. And then this, when it failed, finally Gaia 3 successfully crossed, but it went into a side branch. And mention was made by Dr. Kirti Punamya about the side branch technique, and that we tried to change the direction from a miracle 6 wire, but that would not work, and the wire kept on going into the side branch. At this point of time, I entered the side branch deliberately and confirmed that yes, I was in the side branch in the correct lumen, and the side branch technique, which I think, I presume that it was been talked about yesterday. So Kirti did not elaborate much on this. So I will go that when we do a dilatation at the junction of the side branch and the totally occluded targeted segment, when you dilate at that point, it cracks the proximal fibrous crack. Once it cracks, I think creates a passage available to you for subsequent wiring. And having done that, the anti-grade flow improved considerably. And then at the point of time, I made an injection through the microcatheter to find out the precise entry point. And then whisper wire successfully crossed in the RCA. And thereafter, subsequently, everything else was easy. Daughtering done through the microcatheter, and a long stent was deployed, and that gave another stent also, second stent, and the final result was very gratifying. So just the wire alone is not enough. I think you should know how to use one wire, second wire, correctly for a given situation, because there are multiple variables about this. This lady required multiple supports. It had we did what is known as an anchoring technique by entering into the sinus node branch, and sometimes when there is an issue, the patient has bradycardia, you can deflate the balloon. And this wire, which was a whisper wire, whisper medium support, and that crossed it. And then when there is a difficulty, you can use the anchoring technique. Here there are two wires, one in posterolateral and one with PD, and also one more anchoring wire, which was initially used. At this point of time, we have already removed the balloon out to create a space. And then finally, anchoring one wire against the other, first stent was deployed. Here is the anchoring done once more, and with the balloon distally. And look at the way the guide catheters support from the opposite aortic sinus. You need not be coaxial, you need not be selectively cannulated, but the support has come from the opposite aortic sinus, and the stent has been delivered. And this thing. Atul, please tell me when to stop, huh? Please, Atul. Hello, Atul.
Yeah, you can take at least 2-3 minutes.
All right. So here is the calcified curved tortuous RCA CTO. Distal segment also is calcified and tortuous. Now this is a signature to failure. Tortuosity and calcification combined together is really a signature to failure, because these are most difficult cases, most difficult. Whether you are antigrade, retrograde, ADR, no matter whatever you do, they are tough cases. In this particular case, the Fielder XTR, the Gaia, both failed, and ultimately cyan black worked. The difference between Xeon Black and Fielder XT is this, that it has regular 3 centimeter black tip. That's all, 3 centimeter, so that the visibility is much better, apart from the property of tracking and apart from the property of torquing. Then after that, we took a anchoring balloon because we had difficulty in delivering the hardware. So this is an anchoring balloon technique. We delivered the hardware, serial balloon dilatation done, and then it was stented there. And finally, when there is a blunt tip CTO like this, we also should notice that there is a stenosis tight proximal to the CTO. And that take away a lot of force. It saps away the energy. And that I think should be addressed first. This I think is important to keep in mind, that any lesion in between from the origin of the artery to the proximal fibrous cap or a platform, if there are any tight lesion, they should be addressed adequately first. Here also I entered into the side branch first and then wire crossed by anchoring balloon technique. This was the side branch balloon was providing anchor support and we could carry out, and finally it was, and here the RCA very, very proximal. It has a tapered tip and kind of a situation which you feel that we can cannulate, but we failed. And when you see this kind of a retrograde connection, you should not attempt any further. These are called broomstick. There are, know that we have Werner's classification, CC0, CC1, CC2, CC3, and finally, if this kind of a broomstick connection, they can never succeed. They all will lead you haywire and you don't attempt that. All right, Fielder XT did not cross. Gaia 2 was taken. Let me tell you that how do we escalate? Now that is the prime talk, but escalation alone is not enough. So we need all kinds of technique combined together. As like Dr. Kiti Punanya said, I have on my shelf at least, or when I ask the, when I go to visit a center, I tell them that at least you should have one of the polymer wires, one of the Gaia series, one of the Miracle, and Conquest Pro for sure. If you have this many, that's fine. And to cross here, and 2 long stands delivered. And this RCA CTO was so very tough, so tough that nothing would cross. And in this particular case, I had to use a tonus. And after using a fine cross and balloon when did not cross, the subsequent choice was to the tonus. And after using a tonus, in tonus you keep on doing counterclockwise rotation for 20 to 30 turns, and you keep on spinning it, and then it goes in, and it, even if it crosses partially, that is enough. You can take subsequently low profile balloon and dilate, and you will create a wedge, and it will create a wedge throughout the, and then it will crack the CTO, and then it will make a passage for subsequent hardwares. And this was the result. All cases I prefer to use single stand or minimum number of stands, so they all are long stands. So know the properties of CTO hardware as well. I think you have 2 solid days explaining to you that why you should know the properties of the CTO hardware. Do not force the wire. You can twist it, torque it, and go ahead and further, or you can relate it. Hybrid technique. Most of the time, the retrograde techniques are hybrid technique. True to true, like in a total retrograde techniques are comparatively rare. Switching to other strategies quickly after the initial strategy failed should be unhesitatingly done, and have patience. Thank you very much.
Thank you very much, sir. Kiti.
Awesome talks, very detailed, very eloquently explained. I think you covered almost all aspects of the anti-grade approach. I think we can discuss the hardware. I think the most important hardware is standing on his 2 feet in the cath lab, and that's the most important hardware. And then the rest of it is what happens between the fingers and the mind. So we'll have all the questions coming in, and before we run out of time for this morning session, sir, I'm going to call my dear friend Arun Kalyan Sundaram, who is going to complete the hardware requirements for the retrograde. And then, so we can come back and pick a few questions with you and
Sure.
have it in mind so that you all can give the audience a little, a little comprehensive toolkit knowledge so that, they know what to keep on their shelf, because not everybody is going to be able to have Ashwin Mehta's Cath Lab inventory, and not everybody will have the same skill set. So what would be the basic minimum requirement for everybody to start off a program with, and where and how do they come across and say, okay, fine, these are what we should attempt, these are what we should not attempt? I think those are crucial for all the listeners today. Arun, if you're there, I want to invite you, come in and share with us your experiences, and then
I'm there.
Thank you, sir. Thank you so
Okay.
much. Yeah.
Thank you so much. Yeah. Okay, let's just see. All right, can I start sharing the screen?
Of course.
Okay, good.
Looking good, Arun.
Thank you, sir. Let me just see how to get this going. Okay. I don't know this is. Hold on. Let me just stop and start again. All right. Share screen. Basic. All right, good. You guys see it now?
Yes.
Yeah.
All right. So first of all, thank you so much for inviting me for this. It's been I was able to catch some of the talks yesterday. It was just been mind blowing. You did a great job moderating it. Thank you, Doctor, for having invited me for this. I was asked to talk on wires and microcatheters, specifically with attention to retrograde. And again, it's always a tough act to follow such eminent speakers, but I'm gonna try and stick to time and also kind of cover most of the stuff. So with retrogrades, I'm gonna go over some of the basics. I think we need to understand wires and microcatheters, and I think we already had a lot of that, and some examples at the very end. So fundamentally, with retrograde technique, I mean, you kind of have to get access to the vessel distal to the CTO. So, and the conduit could be a septal, epicardial, or a bypass graft. And then obviously you need to cross the CTO, whether it's antigrade or retrograde. I mean, the traditional one has been retrograde true wire escalation, where you just cross it with a wire retrograde true to true, or reverse card, or the classic card. So essentially you're kind of getting control of the vessel antigrade and retrograde. And then of course you got to finish the procedure itself. Just a few ground rules. Typically when you do take pictures for doing CTOs, I mean, you can often tell if an angiogram has been done by a CTO operator or not. Please don't pan, because it really kind of makes it hard to look at the collaterals themselves. Large bilateral injections typically. We've already kind of gone over this, so I'm going to skim over a lot of the wire stuff. I think tactile feel is critical. We have already talked about wire components in detail. Asim gave a fantastic talk about that. But fundamentally it boils down to, you can only do a few things. You could target one way or another, you could push or pull. I'm going to skip these things because you already talked about it. I think it's important we know our wires and our microcatheters, and that's what this talk is all about. So I'm going to go over that very shortly. It is also important, this incidentally is Corsair. You need to understand which are the catheters which can be torqued, which way. It's a single person job. Don't have your assistant hold the wire when you're advancing microcatheters. That's always a recipe for disaster, because they're going to inadvertently pull the wire. So Corsair tends to torque a little bit better counterclockwise, and so does the Corsair Pro, Corsair Pro XS. Turnpikes tend to do a little bit better clockwise, just because of the way the braids themselves are constructed. Caravelle, as Dr. ABM had just said, is more of a push catheter. So these are all things that I think we need to understand. Again, we've already talked about how to take pictures. The goal, and really I just want you to pay attention to the last one, is you really want to image the lesion as well as you can. The distal vessel, the collaterals themselves, and the proximal vessel. And fundamentally, we know the basics, right? If you don't get a wire, if you don't get a microcatheter across, you can't really do PCI. And why does retrograde matter? Because as we start doing the higher JCTO scores, you really need to have a plethora of techniques, tips, and tricks for you to really treat all patients that deserve to be treated, not just the chip shots. So you got to be familiar with dissection reentry. You got to be familiar with retrograde in all aspects. And obviously, there's a learning curve to it. So we've talked about this. I'm going to kind of keep going here. But do understand that everything contributes to the feel and function. The tip load does, coils, core, coatings. Again, we have gone at length. A few things that I think have not been covered in the last 2 days, and I do apologize if there is overlap. Stiff wires, doesn't matter who makes it, which company. Very, very penetrative wires tend to go straight just by the physics of the whole property of the wire. Knuckles tend to stay in the architecture of the vessel. So that's, and I'll kind of show you a few points to kind of emphasize this. So again, the goal is, like we mentioned, is to go from point A to point B. And you got to figure out how to traverse. And all wires and microcatheters do is to get gear from A to B. And this can be antigrade or retrograde, it really doesn't matter. And so fundamentally, whether it's antigrade or retrograde, if you have a tapered tip, you could choose certain wires. If you have a blunt cap, I'm going to tell you which ones to choose. And if you're just trying to navigate through the CTO body itself, what are you going to do? And of course, wiring collaterals is its own game. Like we talked about, what are all the various maneuvers that can be done? This is from Stefan, so I got to kind of acknowledge him for that. So this is drilling with the torquer, and I think there was some discussion yesterday about drilling with torquer versus drilling without. Pros and cons to both. They're not obviously you can spin a lot faster when you do it without a torquer, because remember you're gonna, some of the torque is going to be it's not going to be as efficient. Once again, the physics of it is, if you're holding a much smaller lumen and you're or smaller profile and you're torquing it, you're going to spin much faster. So you will get higher speeds, lower precision with the hand. Obviously with the torquer, it's going to be higher precision and lower speed. Sliding is just as the term implies, you're just sliding it. And puncture is where you really want to, again, sometimes you drill and puncture, sometimes you just, kind of target it and then puncture. Gaia, I think, has been, Asim has already gone over this, so really works on the principle of deflection, pulling back and then torquing it. One point, and this is courtesy Dr. Okamura, for those that are interested in 3D wiring, great concept, and has been increasingly validated. The point really is, again, whether it's antigrade or retrograde, and I don't think this has been specifically discussed, but the certain wires tend to do better when you rotate and advance them, and some do better, like where you can actually kind of feel your way through. A's, XTRs, etc. The more penetrative wires, the ones with the bigger, beefier penetration forces, you typically want to aim and, so you do your rotation and then you advance. So these can do better that way. And obviously knuckles is a linear act. Notice that there is no torque here because you're going to end up forming a knot. So if you want a knuckle, just push. So with the tapered caps, what do we want? We want something that's, the wire has to be tapered. You don't need a particularly high tip load. It's got to be lubricious and it's got to be flexible in the shaft. Now, if you're dealing with a blunt cap, obviously, whether it's antigrade or retrograde, you want penetration. So you want heavy tip loads, you want penetrative wires, and ideally tapered. And for a CTO, for navigating through a microchannel, you want good tactile feedback. Low to mid tip load's fine. You want really good torque response, and you want something that's flexible. Collateral wiring, you want something with low tip load. Obviously, you don't want to perf the collateral. You want something that's really responsive. So, and you want something that's flexible in order to take all the tortuosities of the collaterals themselves. So the different goals that you have should be matched by what the wire properties themselves and how you use them. So this is kind of like the key slide, I think, that kind of really gives you the details. If you want microchannel tracking, really, I mean, I think for the most part, Asahi owns this whole portfolio. Really, it's the Fielder XTAs, XTRs, Cyan Blacks. For penetration, for cap penetration, again, Pilot 200, the Abbott wire. You got Mongo, Gladius, Raider from Teleflex. This is not yet available in India. The Gaia series, the Judo series from Boston, again, not available in India yet. The Confians are the Conquest Pro 12s. Once again, Asahi Hornet 14, which is really a penetrative wire. Dissection wires are, most of the wires are Asahi again. The XTs traditionally, you have the Mongo, which is a dedicated knuckle wire, a Fighter from Boston. Any wire can be knuckle. Pilots have been the traditional big knuckle wire from Abbott, and then batted again from Teleflex. For re-entry, again, you want something with a lot of penetration. Again, you guys can kind of see it here. This is really, you're looking at the big guns here, the Hornet 14s, the Conquest Pro 12s, the Astatos, 820s or the 40s. And for collateral crossing, the lone wire from outside the Asahi portfolio is Samurai RC. The rest is all pretty much Asahi's. The Xi'an Blacks, XTR, Suo 03. And for externalization, you have R350 from Vascular Solutions, which is, again, or rather Teleflex, not yet available in India, and RG3 from Asahi. So when you do want microchannel tracking, etc., we already talked about this. For the most part, something with a little bit more penetration here, we are looking at Gladius, which we should be getting soon. The Mongo, Raider, which is from Teleflex, and the Pilot 200s, which you already have. The higher penetration forces, really, wires are the Gaias, which you have. The Gaia Next, hopefully we should get them soon. And the Judo wires, which are both, kind of has a hydrophilic tip and is pretty torqueable and is tapered. So again, not yet available in India. Again, the really big guns are the Confianza series, the Warrior wire from Teleflex, and the Hornet 14 from Boston. And again, the biggest gun on the block is really a Stato 40, which I think is not available in India, but it's available in Japan, I'm told. We can go as high as the 820, so functionally it's very, very penetrative. The knuckle wires, Fighter, Bandit, and of course the Asahi wires are Mongo and the XT series. The retrograde wires, we have touched upon this, and I'll kind of tell you specifically just to simplify this whole laundry list of wires. Xi'an is pretty much standard across the board, can be used for septals and for epicardials. Xi'an Black if you want to serve, or the Samurai RC if you want to serve. XTR if you're looking at a super, very, very fine collaterals. Suo 03 when you're just dealing with wicked tortuosity. And Suo 03, I think, merits its own slide. It's a wire like none other. I think Asim kind of talked to you about the construction itself, so I'll kind of skip through that. But the key is, this is a wire that, I mean, even people like me that tend to go without torque many times, you want to really torque slowly. Let the wire kind of find its own path. It really, and do it no more than the heart rate itself. You want to really not push this wire. You don't want to over torque it, etc. Kind of let it find the path, the channel itself with a heartbeat. So you gotta be very meticulous when you're wiring with a Suo 03. This really is kind of like, again, a summary slide for wiring collaterals. Suo 03 can be used pretty much across the board, and it's applicable even in a septal. Xi'an, again, as you can see, works really well across in a lot of settings. When I'm looking at invisible collaterals, I tend to go Xi'an Black. And obviously, after you have done the retrograde part itself, you still need to externalize. So you want really long wires. The only one available in India right now is the RG3 from Asahi. Microcatheters, again, I think Dr. ABM has kind of talked about this. Antigrade, it still applies to retrograde. I understand there's a lot of microcatheters out there. So you want to, I'm just going to spend a little bit of time here. For the general purpose, I think Fine Cross works great. The rest is really not available in India yet, so I'll kind of skip that part. I think over-the-wire balloons are passe. You really shouldn't be using it in 2020 if you want to be respected as a CT operator anymore. Retrograde, if you're looking at fine collaterals, Turnpike LP when we get it, hopefully next year. Corsair Pro XS once we get it. Otherwise, you're still dealing with Caravel. Mambaflex not yet available here. And both Corsair Pro and Turnpike can be used to antigrade and retrograde. These are the beefier microcatheters. Antigrade specifically, you can't use the spiral retrograde. It's much harder. And Turnpike Gold and is similar to Tornus. It's really when you're dealing with a lot of calcium, only antigrade. So we've kind of talked about this. So I'm gonna just go to the summary slide here. Again, this is key. If you notice something, the Turnpike LP and the Corsair Pro XS are really the torqueable microcatheter is low profile. The Caravelle is a non-torqueable, so you really just want to push it. And this is what you want to use when you're dealing with fine collaterals, especially epicardials. Again, Dr. ABM has kind of talked about this, so I'm not going to spend a whole lot of time. I do want to emphasize that Corsair Pro is a iterative step up over the Corsair, which was available until last year. Much better in terms of torque, deliverability, etc. Also, the back end has been reinforced, so you tend not to the torque transmissibility is even better. Also, the tip has been strengthened, so the problem of over torquing and breaking the tip of the catheter doesn't apply anymore. I'm super excited about when we get the Corsair Pro XS. Used it once, but it's been like, I mean, the response has been fantastic for people that tend to torque. It would be a game changer, pretty much. This is from Teleflex. Again, not yet available. Hopefully next year. This was again has a whole panel of microcatheters and a family of microcatheters that I'm kind of excited and looking forward to it. Mamba is from Boston. Again, I'm not going to spend time on this because we don't really have it. I do want to spend a little bit of time on the dual lumen catheters. These are incredibly useful. Twin Pass is what's available in the West, in the US. Asahi, again, Sasuke, not yet available in India. But this is the only dual lumen microcatheter that you can actually take through a collateral and actually use it. And I want to emphasize that has the lowest profile amongst the dual lumen microcatheters. The only one we have is Crusade from Kaneka, which again has been around. It's a great dual lumen microcatheter. Why do we use them at all? For starters, it certainly helps you. I mean, when you're dealing with a blunt cap, etc., particularly useful. Sometimes you need it to enter a collateral itself, and certainly increases the pushability in terms of comparing it with a single lumen catheter or a dual lumen catheter. You're going to get a lot more penetrative force when you do use a dual lumen catheter. This kind of illustrates why it particularly works well in blunt caps. And again, if you want to take anything at all across a septal and then you want to penetrate, the only one that you can use is a Sasuke. So if the Japanese were kind enough to leave any, save them, use them. So that's particularly useful when you're dealing with a blunt cap, retrograde. Many times you do come across this as a problem. So entering the collateral itself sometimes can be challenging. Multiple techniques here. In the interest of time, I'm not going to spend a lot of time on each of these, but this is something that we do need to know. And sometimes you do have to use a dual lumen catheter even to enter it. For septal surfing, like I said, Cyan Black is pretty much workhorse. You could use a Samurai RC, a Fielder FC if you don't have a Cyan Black, but there's no reason for you not to. You should talk to a CM if you don't have it. And for wicked torch velocity, really, Cyan or Suo 03. This is just so when I'm surfing, typically I don't use microcatheters. As you can see, go pretty fast, push pull with fast drilling, and here again, there is no one right way. I mean, there are some people who would balk at this and say, "What are you doing?" But surfing works it's very safe, especially with septals. You never surf an epicardial. I do want to emphasize that. And when you're going from the PDA to your LAD, it's a lot harder just because you're dealing with a lot of the torch velocity up front. Getting in could be challenging. Many times for these, you might end up using a Cyan Black or a Suo 03. And I'm just going to let this play. So you don't have to see the entire thing, but these can be particularly challenging. And you can navigate really complex, tortuous collaterals this way. So the keys for septal collateral crossing really are know the anatomy. You could either do a tip injection or you could surf. Really no right answer. Understand that usually LAD to RCA is going to be easier just because you're dealing with less tortuosity up front. Getting in from the PDA to the LAD, it's a little bit of a challenge, but you can do it. Many times, like I said, you might need a dual lumen catheter even to get in. You could inject, you could surf. No right answers. Now, a word about retrograde dissections. Sometimes you're dealing with stuff like this. So, supercalcified, long RCS CTO. Good luck trying to wire this. It doesn't matter how good you think you're at wiring. You're not going to be able to do this true to true. So in these cases, just knuckle. And I'll kind of touch upon this shortly. So as you can see, knuckles are a very safe way to traverse long distances efficiently. Then you can follow this up with a microcatheter, retrograde dissection, as you can see, knuckle, knuckle, knuckle. And then once you're up here, you're close, get an antegrade knuckle. And now you're in the game. You have two knuckles dancing, antegrade and retrograde. It's a lot easier post stenting. Knuckles are typically safe because, like I said, this is from Bill Lombardi, and really, they did this with a 3D printer. So I'm going to just use this. A stiff wire can penetrate, and I think it's kind of a cool video to just show the point. And here is a knuckle, and once a wire is knuckled, it tends to stay in the architecture of the vessel itself. I just thought it was kind of cool, so I asked Bill if I could use it. Now, if you're not doing retrogrades, please forget the rest of the talk. These are epicardials, and it's probably aimed at a higher level audience. But the key point is you need to understand how to tip these wires, and sometimes you will have to put in a secondary bend in the 203, even if you can get it pre-shaped. And you sometimes you can navigate really tortuous collaterals with the SUO 03. Like I said, being a true game changer, you got to be, this is not your first 100 retrogrades, but these can be done. The key is to just be very, very patient. And even as you're advancing the microcatheter, you got to be extremely slow. Ensure that you never push too hard against resistance. All right. So these are the kind of collaterals that can be done. This is a Circ CTO. Again, I'm just gonna antegrade really didn't work, unfortunately. So had to use a dual lumen catheter to even get into the collateral of interest. And I'm just gonna show you this collateral itself. So dual lumen catheter to enter it, and then that's the epicardial itself. As you can see, again, these can be done. This was done with a Caravelle and a SUO 03. And once this was done, the rest, again, a bad angle of exit from the collateral itself. But anyways, I'm not getting into the details of how I did this case itself, but that's the final result. So the point I want to emphasize is that, again, I don't want to keep showing you epicardial, so I'm going to kind of take a break here and just go to my summary slide so that we can actually have a meaningful discussion. And I'll just see if there's anything in particular. So, okay. So, so I don't know how much time we have. So, I think we are running already late. So I'm going to just cut to the chase.
Actually, we've 1 o'clock was the closing time, so
yep.
we have past that. And,
I figured as much, so that's why I want to kind of keep it.
Why don't we take a shot? We just take some of the burning questions that a lot of us might have and things.
So
like
can I just go to my summary slide and finish up, Kirti, and then I could that's kind of the plan. So, the one other thing is you guys should know how to snare if you're going to do epicardials or. Retrogrades, not epicardials. In conclusion, really, just remember anytime you're doing retrogrades, be extra careful when you pull stuff, because inevitably you're pulling through a lot of other stuff. Remember what else is going to get sucked in when you pull something. Learn the steps. Obviously, never dilate an epicardial, never surf an epicardial. It definitely is an important skill set if you want to enhance your success of CT or PCI. Multiple steps, crossing the collateral is just part of it. Be prepared to deal with complications. Use proctors when able. Thank you very much.
As usual, also, it was an absolutely amazing talk. Wish I had a little more time where I could continue listening to the amazing insight that you have in this field. Atul, why don't we just go ahead with questions? And
I think before we take specific questions, or before maybe VC or Prashant wanted to show some case for discussion purpose, but I think one question that I would have everyone answer is that if people want to know that what minimum hardware in terms of wires, if they want to do CTO, they should have? One out of these three, one out of these three, one out of these two, or whatever. So what would be the advice? Can we start with Sir Dr. Abhimeta? What would you
Yes.
advise?
I would say that the people who are at the lower level of learning curve should do only antigrade cases, should not dwell onto the retrograde cases until they have done about 100 cases. And that too, when you do the retrograde cases, it should be proctored. The hardware, I said, right, this question was raised even earlier too. I would have one of the polymer wires with a low tip load like either Filter XTA or Filter XTR. And why should I say either? I will have Filter XTA. The second wire I will have a Gaia 2. And the third wire that will have is a Miracle 6. And the fourth I will have is a Conquest Pro 12. This will meet with my 90% of requirements.
Arun?
XTA, Gaia 2, Miracle 6, and Conquest Pro 12.
Arun?
Yeah, I'll just add one more to the mix. I mean, I typically, I mean, if you're just starting off, and if you're, I would say first keep your pericardiocentesis kit. You should know where that is. You should have covered stents. You should always have stuff that's going to save you if things go wrong. You should be good with imaging. There's no point doing CTOs if you have not learned the basics. So I think imaging in today's day and age is critical. Now, that being said, if you're just starting off with anti-grid, I would say for the most part, your Corsair 135, if you're never going to go retrograde, then use the 135. It's way more torqueable, or a fine cross, whatever you get. Keep one microcatheter for sure, along with all the wires that Dr. ABM said. My personal choice would be for the CTO wires, keep either, XTA would be fine if you're just going to go anti-grade. I would typically also have a polymer jacketed wire, such as a Pilot 200 UB. I mean, pick one. Pilot 200 would be my choice. After I saw Kirti, and especially after I moved back to Asia, I've started using a little bit more UB3s. I kind of like that. Definitely keep a Conquest Pro 12. I used to use a lot of Miracles. I don't use them anymore except to deliver Stingray balloons. So I would say XTA, Pilot 200, Conquest Pro 12, and a microcatheter. UB3 just because I like it, and I'm playing with it quite a bit, but it's good.
So we see Kirti, Prashant, you want to add anything? Or?
Yeah, see, I want to add, as far as wires are concerned, both of Dr. A.B. Mehta and Arun said very well. But like you and Kirti, I was also lucky and fortunate to work with Dr. A.B. Mehta, and that was 1988. I hope you remember. It was.
Wow.
Of course I remember.
And Dr. Munshi and yourself were doing one of the first angioplasties in India at that time. And the most difficult thing was to prepare the balloon. And I had never imagined that over a period of time, though the balloon, wire and stent technologies progress, it is still the wire manipulation that remains the most important part of the challenge. The rest other things are easy once you cross the wire. So I still remember the days of 1988 and the way you progress. And I would definitely consider Dr. A.B. Mehta is one who is kept up with the time. Like Arun Kalyan was a new guy who is doing everything, but A.B. Mehta, though he started in 88, is still doing everything. Unlike many other people who have retired and stopped doing. So you are really appreciated.
VC, I mentioned your name. I mentioned people who had a direct training like you, Atul.
Yes,
and
that was really amazing.
Yeah. And I'm eccentric, man, a little bit. So I keep on doing and driving cars and all kinds of things. Anyway,
so that's why you are
I
able
would say
to open
inspiring,
eccentric
Dr.
lesions.
AB. I'm not eccentric. I would say inspiring.
No, man dealing with eccentric lesions, not the eccentric man. That was good.
Okay. All right. Okay. But I'm proud of all of you three. Everybody.
Thank you.
Okay.
Kirti, you want to comment on that for anything further, or you want Prashant or VC to show one of the cases?
I would like others to talk, and so I would love to hear what Prashant has to say, and I think it's important. Prashant, are you there?
He's like muted and off video.
Maybe he's having lunch, or he's been another something. But okay, till Prashant comes back, I think for me, as I think one from each series is important. So it's very important to start with your workhorse wire and then get to the cap and then move to either an XTA or an XTR, and one could make a choice as to which one they want to keep in their inventory from that. The XTA is better because it's a little more solid than the XTR. Actually, the XTR kind of fails more rapidly. Then I would almost always want to have a UB3 for certain anatomies, which I am very, very fond of. I've given up the Miracle series entirely. And then, of course, I would have the Gaia second and the third both, and I would have the Conquest Pro. So I want to have a little bigger, a little bigger wallet of wires on my shelf. Having said that, nothing to take away from the guiding catheters. I think we didn't mention it, but guiding catheters today, it was not the theme of the topic, was more wires, and so we didn't talk about it. But the plethora of guiding catheters are important. The guide extension catheters are important because they have made life better for us. And the way you need to use the guide extensions is you need to have a pre-thought and then start with telescoping the guide extension over your microcatheter, launching it into the coronary, and then exchanging over the microcatheter, because you cannot afford to go outside the guide extension with a wire. That's one, very important. Besides that, I think between Dr. Mehta and VC and Arun, I think most of the things have been covered.
I have one point.
Yeah.
That because the CTO is never ad hoc procedure, is it possible that majority people, especially in periphery, may keep XTRA at the most, and whenever there is a CTO case, real is genuine CTO difficult case, then they can plan it some other time, and that time get invitee and maybe some of the proctor like you? Would that make it more cost beneficial to the periphery or other setup?
I think it's absolutely perfect. In fact, what we all are trying to say today, and Arun kind of almost spelled it out in his last couple of slides, is that for beginners, I think you need to pool those cases so you can have all these cases on one particular case. So it's easier for the industry to mobilize equipment for you guys. Industry can also mobilize experts. I mean, I know Dr. Mehta has gone prolifically all around the country and seeded the idea of CTO angioplasty in remote areas. I know Arun Kalyan Sundaram has done that beyond the shores of India. I mean, I every time I enter a cath lab anywhere in Asia, I see a picture of the local prime minister.
Really?
Yes, I know that. It's true. I saw that in Sardang, so you can't say I didn't see it. And then I think there are many guys, I think, who are proctors, and I think each one will have his own comfort level with others. But I think on this podium itself, I think I can see two absolutely prolific guys who are great proctors. And I think proctors is essential because it's not the tactile feel. All that is given away. It's your mind, it's your thought process, it's your temperament, and it's your planning, and you're able to, it's a puzzle which you have to mentally decipher in your head, and you got to make a roadmap, and then you got to stick on the roadmap, and then there will be detours that you got to take which are unconventional. That's where experience matters. But
the term is cognitive skills before hand skills.
Yeah, like Atul, I think the finest aircraft ever made is Rafale, but you must know how to operate it.
Absolutely.
Fantastic aircraft, but you must know how to operate it.
exactly.
And second thing I realized that maximum you learn is not attending webinars or conferences or courses. Only when you have your own patient and some proctor comes and teach you, that is the only where you learn the maximum.
Absolutely.
So that is why I thought of saying this thing.
Correct, I agree.
I said it better, really. I think any other questions, Atul, that we need to ask?
Of course, another thing for new people is don't get mesmerized. Yeah.
So BC, you wanted to show just one case because we are already beyond the. and
No,
time,
because
but
we are late, I think we'll keep it some other time, because one case will take 20 minutes if you want to really discuss.
One
But
quick,
just I want to tell all the young people that don't get scared by the technological detail or the detail that Guidewires had. You have to just know how that wire work and how what is the skill required. Like if you know, as Abhi Mehta very rightly say, if you drive a car, you don't need to the machine and the technology behind, but you should know what are the principal points, complications, and the way in which it works. So that is true for the wires. So next time we should give a lecture for young people, condition and what wire should be used rather than wire and what condition it should be used. Other way
right,
around.
true.
I think, Atul, that could be an idea for your next ideation session, where we put arteries and put lesions, and
I
have
think
experts give an opinion on how they would and discuss it through the case, and then maybe the operator can say where he got stuck and see how far from the truth he was or how far from the gospel he was.
I think to add to VC, you should also know what not to do with certain hardware, because that is what creates complications. So you should know that now with the automatic cars, you shouldn't press the brake switch all of a sudden while driving. The parking, this thing is now on a very small switch, and sometimes inadvertently you may press parking, which I have done once.
Yes.
I pressed the parking assist while I was driving my car, and it suddenly said, "Stop your car and keep the engine running." So I was scared as to what is happening. So similarly, when you're using the CTO wires, especially, you must know what not to do and where to be cautious. I think that would be. I think in the next part, as you suggested, when we discuss cases, we can discuss about where to be very careful. And also, one of the point I think which we didn't mention is the de-escalation of wires once you have crossed. Because
I briefly mentioned it, but I guess it was too quick a slide. It's very important to toss between escalation, de-escalation within the CTO body. Exactly.
Yeah.
It's an awesome afternoon. I think we should call
so
it.
Prashant is back, maybe after his lunch or whatever.
While I will easily allow Atul to do an angioplasty on him, I've realized that I will not allow him to drive me anywhere.
Okay.
So Prashant, do you have any comments? Otherwise, we'll close and you're muted, Prashant.
We had good discussion, and it's already getting late now. So nice lectures from all the stalwarts, I would say. Practical description, very, and I think we should continue this TOTT program in future. Discussing various aspects of interventions.
Also for the benefit of the audience and the participants, that the TOTT will continue on other aspects of angioplasty also. That means we'll be talking about balloons, specialty balloons, catheters, guiding catheters, the mother and child kind of guiding catheters. So there will be different sessions on various other hardwares. So looking forward to everybody's participation in those sessions also. When we plan the date, we'll obviously let everyone know. I am really thankful to all the panelists and those who have delivered talks today, and also Asim. So thank you, and last word to Kirti, and we will close.
I think, thank you, Dr. Mehta, Dr. Chauhan, Arun, Prashant, Atul. Atul, I can't thank Atul enough for actually being the entire body of energy, pushing me out of my initial inertia with a couple of calls at 11 in the night and say, "Oh, Kirti, wake up and we need to talk about this." So I think without Atul, this would not have happened. Atul, thank you, because it has been an absolutely amazing session yesterday and today. And I look forward to your ideations to kind of shape our future programs as well. And thank you to the rest of us as well. It has been a great afternoon.
Yeah, and I would like to add last sentence.
Yeah.
The taught us a lot.
taught you a lot.
I hope
Taught you a taught.
VC, I am good at acronyms. You asked Sir Dr. Abhimeta that I coined the term STAT for cyan thrombolysis angioplasty trial, which was the first primary angioplasty.
Right, I was going to mention that, I think, the STAT, I think. And Kirti, Atul was after your blood and he was pushing you all the time. Then let me tell you, this is his habit. He dragged me in the middle of the dream night to Bombay Wizardry.
Yeah, but
That's his habit.
You know, Atul and I go back from 1977 back, right from our first MBBS days. Atul was the most brilliant student and always in the topper, and I was the last bencher. And somehow I realized very early on that the only way that I'm going to be a doctor is hold on to his tail. And so I made sure that I even went and stayed in the same room as he. So lot of it, some of it I read, but a lot of it was imbibing knowledge from Atul's presence around me, because Atul was this brilliant guy who would be able to rattle out Guyton and Harrison backwards rather than frontward. You know, he was that good. So Atul, thanks for always being there.
No, but Kirti, you know why last bencher do better than first bencher many times? Because first bencher don't see what is happening behind. Last bencher see everything what is happening in front. So that's how you learn all the skills.
Thanks a lot. Yeah, it was a pleasure.
Thanks.
I'm going to see you guys. Yeah.
Thank you, everyone.
Thank
Thanks.
you.
Bye.
Thanks.
Bye-bye.